We're going to start with John Oudyk and Dr. Peter Smith. John is an occupational hygienist with the Hamilton Clinic of the Occupational Health Clinics for Ontario Workers, and Dr. Peter Smith is a senior scientist at the Institute for Work and Health. He holds the Canadian Institute of Health Research Chair in Gender, Work and Health. And thank you, John. Peter, we appreciate what you're about to take us through, and with those introductions, I think I'm going to be turning it over to you, John, at this point to begin the presentation. Thank you all. And John, I think you'll have to unmute.
There we go. Thank you for sharing for the opportunity to share our results. First of all, we'll talk about the organizations we come from, and I'll turn it over to Peter to describe the Institute for Work and Health.
Thanks, John. So, as you said, I'm Peter Smith. So the Institute for Work and Health, for those of you who are not familiar with what we do, we're a not-for-profit, non-government research organisation. We're primarily funded through the Ministry of Labour, and our job is to provide evidence-based guidance for policymakers, health and safety associations, workers and employers. And I think what we try to do is provide research that's relevant to those organisations as they move forward. And for those who want more information about the Institute, they can go to our website, which is www.iwh.on.ca.
Okay, thank you, Peter. And I belong to the Occupational Health Clinics for Ontario Workers, which is an interdisciplinary occupational health team with doctors, nurses, ergonomists, hygienists, community organizer, coordinators, and leadership. And we're funded from the Ministry of Labor's Prevention Branch, and our board of directors is represented by organized labor. The services we provide are individual client services where we determine work-relatedness. We do not do treatments or anything like that. We answer questions about work-related health issues. We do presentations. We can also visit workplaces if requested by the co-chairs of the Joint Health and Safety Committee. And we also do more elaborate exposure and health investigations. Now, the background to this survey was we were invited to help with healthcare unions in responding to infection control procedures, draft versions of those from the Public Health Ontario and Public Health Agency of Canada. And this was based on a relationship we had with the unions going back as far as SARS and H1N1 and Ebola. So while we were reviewing the literature coming out of China, we noted that a number of surveys were done to characterize the mental health risk of healthcare workers in China. So we floated the idea to the connections we had, and we came up with an ad hoc team to devise a survey. The members of the group included representatives from various unions that have healthcare units, some healthcare unions predominantly. Also, the Canadian Federation of Nurses Association or Unions, the Ontario Federation of Labour, a number of BC unions. Guy Potter, who is an occupational psychologist with Duke University in North Carolina, and he comes to us via the Copenhagen Psychosocial Questionnaire International Network, Peter Smith, and a variety of other academics and activists from Canada and the US. So the purpose of the study was to try to capture the experience of workers during a pandemic in real time. After the pandemic, when people reflect on what happened, I'm sure that a lot of the experiences will be reinterpreted. So we wanted to collect it as it happens. We also designed the survey to be filled out repeatedly, so as conditions change, they could fill out again. This study only looks at the first responses they provided. was launched April 6th. Responses are still trickling in at about 1 a day. And after we did the survey, we realized that non-healthcare workers should also have a voice, and therefore we launched the second survey April 26th. And again, some responses are still coming in. The content of the survey, we have a number of psychosocial symptoms: stress, burnout, sleep symptoms. We had 2 scales that screen for anxiety symptoms and depression symptoms. We had an acute stress scale, the scale that measured self-efficacy. We custom made some exposure scales on personal protective equipment adequacy and availability. We similarly scales for preventive measures and procedures and for training. We used some pre-existing scales for our various psychosocial factors. So the study samples for the healthcare workers, we had over 7,000 respondents who started the survey, of which about 6,000 did enough of the survey to be included. For the non-healthcare workers, we had just over 5,000, where almost 4,000 were included in the study. It was predominantly a good portion from education sector and government sector, healthcare and social services sector. And here's a picture of the responses over time. We thought time was important because the way things were at the beginning of April may not be the way things were at the beginning of May, although later on we found out there was not much difference, but we thought there might be, so we tracked the time carefully when the responses came in. And most of the responses came in by the 1st or 2nd week of May. Now here's some of the answers to the questions about exposures. The percent or the number of infected patients in the organization, 58.7% of the respondents said in the healthcare survey said they had at least 1 or more patients in their organization. 22% said they didn't know, which was quite alarming that a healthcare organization wouldn't know whether there's an infected patient. Then we asked about exposures to COVID patients, whether they had direct contact, whether they were in the same room or on the same floor. And also we asked questions about the number of workers that were infected. And again, over a third did not know whether or not other workers in their workplace were infected. When you break it down by job category, you can see quite a difference. For instance, in the direct contact, you see paramedics with 89% of them saying that they had direct contact with a COVID patient. When you look at the number of workers infected, you can see that social work and technicians and paramedics had some of the highest rates of reporting at least 1 or more colleagues being infected. For contact tracing, 46% did not know if their fellows were infected with COVID, which is amazing since they were the ones who are identifying who's infected and who's has a contact with them. Then we also asked whether or not you tested positive, and dietary aids had the highest rate of testing positive. And then we also asked about fear, and you can see the dietary aids had the highest level of fear, which is appropriate since they had the highest level of testing positive. Other jobs that were connected with high levels of fear were cleaning, PSWs, maintenance, and LPNs. And if we looked at some of the contact with patients and whether when people were exposed to COVID, whether they were told to work despite exposure, And cleaning staff, dietary aides, maintenance, and PSWs were the most frequently reporting that they were told to work despite being exposed. The same with symptoms, being told to work despite having symptoms that seemed like COVID. The predominant was management and social work, followed by LPNs, contact tracing, and clerks. Told to self-isolate, you see contact tracing, cooks, coordinators, and counselors are the most common. And being tested for COVID, the most often are cooks, the least often are paramedics. Yet when paramedics are tested, about 10% of them were positive. Dietary aides, again, about a third of them were tested positive. We also asked the question about their current level of fear about this whole pandemic situation. And here we have the healthcare average being 6.6 on a scale of 1 to 10, which ranges from little to no fear at all to as much fear as I've ever had. And note that 11% of healthcare respondents picked the category of as much fear as I've ever felt. For non-healthcare, their level was 1 point lower, their average 5.6 out of 10. And you can see that their level of maximum fear was much lower than healthcare. Are you concerned about bringing the virus home to those with whom you live or your friends? And 43% of healthcare picked the highest end of that scale, extremely concerned. The average was very concerned for healthcare. For non-healthcare, the average was concerned, but again, about a quarter were extremely concerned. Our main outcomes for this presentation are the generalized anxiety disorders screening questions and the patient health questionnaire screeners, which are for depressive symptoms. And the questions are patterned over the last 7 days. How often have you been bothered by the following? Feeling nervous, anxious, or on edge, not being able to stop or control worrying. And for the depressive symptoms, having little interest or pleasure in doing things, feeling down, depressed, or hopeless. And the response options are not at all, several days, more than half the days, nearly every day. And because there are 2 questions, you add them together, and this range is anywhere from 0 to 6 for each of these 2 scales. And here you have the results, the healthcare in blue and the non-healthcare in orange. And the screening criteria for the anxiety disorder screener is 3 or more of the 6 possible scores positive, or a score of 3 or more, and 55% of the healthcare sample scored 3 or more, and 42% of the non-healthcare sample, which is quite amazing that over half the healthcare sample screened positive for anxiety problems. The distribution of the depressive symptom scores was similar, but not quite as severe, but still 42% of the healthcare sample screened positive and 35% of the non-healthcare sample screened positive. You can combine these 2 into what is called the PHQ-4. It's a screening scale for both anxiety and depression, and the numbers are similar. However, here you can also see the breakdown according to the categories, green being non-minimal, yellow being mild, orange being moderate, and red being severe. And you can see here that for each of the top categories, the healthcare is at least 5 percentage points more than the non-healthcare. And for the positive category of none to minimal, it's 10 percentage points less. We also ask questions about psychosocial factors and symptoms, and you can see here the ECOS 2019 is a survey that we did last year across Canada, a representative sample, And although these were not systematic samples like the ECOS ones, they do give you a picture of how they compare. And you can see that healthcare has a lot more symptoms and exposures, except for colleague support. They're actually much better than the 2019 average. The non-healthcare has its issues too, but things are not as severe for some of the psychosocial factors such as work pace and role conflicts. And this is consistent with what we found in workplaces where we've done this survey both during the pandemic and before the pandemic, and compared the two. And also we have here the symptoms across the different jobs. And if you look crosswise, you can see that cleaning has a lot of symptoms of anxiety, depression, and the COPSUX symptoms, along with acute stress. And technicians, along with PSWs, the LPNs, and the dietary aides. We'll focus on the anxiety score and the depression score from the GAD-2 and the PHQ. For personal protective equipment, we asked questions whether they had appropriate type and adequate supply, and if so, we said their needs were met. Then the other possible categories were appropriate type but inadequate supply, inappropriate type but adequate supply, inappropriate type and inadequate supply, or needed but not available at all. And this included gloves, eye protection, face shields, gowns, hand sanitizer, soap, running water, surgical or procedural masks, N95s, elastomeric respirators, and PAPRs. And here's a breakdown according to different jobs. And you can, from this, you can also see that gloves and hand sanitizer were better for needs being met, whereas surgical masks and procedural masks and N95s were the lowest for needs not being met. Or when you looked at it across these, if you add them all up and average them, you can see that paramedics are doing probably the best, with just over 70% of them having all their PPE needs met. And the ones doing the worst are RPNs, which stands for registered psychiatric nurses, also PSWs, LPNs, and clerks. And at this point, I'll turn it over to Peter.
Thanks, John. People can see the slide deck I'm sharing. So as well as PPE, so if you think about a hierarchy of controls in terms of ways to control infection from COVID, PPE would sort of sit down the bottom of that hierarchy. It's at the level of the worker, and it's probably the least effective from that perspective, that you're really trying to control it at the level of the worker. So we also try to assess other infection control procedures. So these are procedural changes in the workplace or engineering changes that a workplace might institute. We asked these questions for both the healthcare survey and for the non-healthcare survey. In both surveys, we had the same type of response options. So you can go from a need being met, which is where the respondent said it was appropriate and adequately implemented, to other types would be appropriate type but inadequately implemented, and the inappropriate implementation, lacking, would all be where we'd say the need was not met. So in the healthcare survey, we asked about procedures, infection control procedures such as screening incoming patients, making sure symptomatic patients were wearing masks, cohorting patients, engineering things like ventilation systems and airborne infection isolation rooms, adequate access to personal hygiene facilities and house cleaning practices. We changed these, the response options were the same, but the number of infection control procedures we asked about were different in the non-healthcare survey. So in the non-healthcare survey, we asked again about things such as isolation, but we also asked a lot about physical distancing from both clients and customers and also from co-workers. The disinfection of high-touch surfaces, laundry facilities for work clothes and work-related materials, and also other changes that could be made, like staggered schedules, places to change to and from work clothes, physical barriers in the workplace, and obviously increased ventilation. And again, respondents could say that these things were appropriate and adequately implemented all the way down to where they were lacking. So taking the PPE and the infection control procedures together, what we did is we focused on the number of needs a person had, which is where they said they needed this type of PPE or this type of infection control, and if those needs were met. And using that approach, we could classify people as having either 100% of their PPE needs met, having just over half to, or 50% to 99% of their PPE needs met, having 1% to 49% of their PPE needs met, or having none of their PPE needs met. And here you can see the distribution. The blue bars are for the healthcare sample, the orange bars are for the non-healthcare sample. 100% of needs met is on the left-hand side of this graph, with 0% of the needs met being on the right-hand side. You can see the distributions change slightly for the healthcare and the non-healthcare sample. In the healthcare sample, only about a fifth had 100% of their needs met, compared to over a third in the non-healthcare sample. And then you can see in the healthcare sample, then most of the sample tends to be somewhere between 1% and 99%, with very few, only 8% having 0% of the needs met, whereas that's double in the non-healthcare sample, where 16% had none of their PPE needs met. We can look at the same for infection control procedures, again, among healthcare workers and among workers who are on site in the non-healthcare sample. Again, similar differences in the distributions here, where slightly more of the non-healthcare sample had 100% of their infection control procedures met, compared to 17% of the healthcare sample. And the other end of the distribution, 14% of the healthcare sample said none of their infection control procedures were met, compared to 22% of the non-healthcare sample. So one of the things we wanted to do was examine the relationship between the proportion of needs being met, both in PPE and in infection control, with the two outcomes we had, which was the anxiety screener and the depression screener. But when you're doing that, you want to make sure that you're taking into account other things that might be associated with increased levels of anxiety and increased levels of depression, so that we can sort of isolate, if you like, the relationship between the adequacy of PPE and the adequacy of infection control procedures on anxiety and depression symptoms. And so we had some models, we ran some regression models which were adjusted for a variety of different covariates. The asterisks in this slide refer to things where we only asked in one sample. So we looked at other demographic characteristics, age, gender, visible minority status, things about where the person was living, if their location was urban, suburban, or rural. We asked if they were, for the non-healthcare sample, we differentiated between people who were still site-based workers from those that were working remotely and those that had lost their jobs. In the healthcare sample, we asked about the type of facility. So we have not just hospitals, but also people in retirement homes, community care institutions, long-term care settings. For all workers, we asked about their current job tenure, the hours of work. In the non-healthcare sample, we asked if they were a supervisor or a manager, or the workplace size. Then we asked a number of questions about COVID. So if they had contact with COVID patients, which was obviously the healthcare sample, the number of patients they had contact with, the number of workers who had been infected with COVID, if they had contact with someone who was later diagnosed with COVID, and also if they'd received training in relation to COVID and in the donning and doffing of PPE. And as John said at the start, also we looked at the data of the survey to see if there were changes over time. So we're fairly confident by being able to adjust our estimates for all these other factors that we do have, we have a high chance of isolating the effect of the adequacy of PPE and infection control on the depressive and anxiety symptoms. So this is for the healthcare sample, looking at the proportion of PPE needs that have been met and infection control procedures that have been met. So PPE is on the left, infection control here is on the right. Infection control's got the slightly, you've got the blue shading across it. But you can see for both PPE and infection control, there's this clear graded relationship between the proportion of needs that have been met and anxiety symptoms. So focusing on PPE, for those that had 100% of their PPE needs met, 43% of that group had anxiety symptoms, whereas in the group that had none of their PPE needs met, 61% had anxiety symptoms. So that's a difference of 18 percentage points on an absolute scale there. Similar relationships for infection control, 44% in the bottom group compared to 61% with anxiety symptoms in the top group. Focusing on depression, again, smaller proportions or prevalences of depression in our sample, but again, you can see this graded relationship between where PPE needs are met, 100% of the needs are met at the lowest prevalence of depression, the sample where none of their PPE needs met at the highest prevalence of depression. You can see here a slightly stronger relationship for infection control procedures, so a 19 percentage point difference between the bottom of the scale with 100% of needs being met compared to the top of the scale where 0% of the needs are met. So these are quite clinically important differences from a population health perspective around strategies that a workplace can put in place to reduce depressive and anxiety symptoms among workers. For the non-healthcare sample, it's a little bit more complicated because we had a sizable group of that sample who were working remotely. It was about 40% of the sample were working remotely. We had another 45% of the sample which were site-based workers, and then a much smaller percent who are no longer employed. So again, we have to sort of tease apart here where we have the workers who are working remotely. If we just compared working remotely to site-based work to losing your job, you can see, I guess, what you'd expect to see in terms of a gradient where symptoms of anxiety and depression are higher among site-based workers than they are among workers who are working remotely. And site-based workers have similar prevalence of anxiety and depression symptoms compared to site-based workers and those who are no longer employed. But it becomes more interesting when we start breaking it down again by PPE and infection control procedure needs. So these are for our anxiety scores with PPE needs, and you can see if you were to compare people who are working remotely to those who have all of their needs met, they actually have a very similar prevalence of anxiety symptoms. And the group, again, with the highest prevalence of anxiety are those who are site-based workers still working with none of their PPE needs being met. So these have 52% of that group have anxiety symptoms, and that's even higher than those who are no longer working, where the anxiety symptoms are 44%. Even a stronger relationship when we compare infection control procedures among non-healthcare workers, where, again, compared to those workers who are working remotely, where 35% of those have symptoms of anxiety, only 30% of people who are at work with 100% of their needs met have symptoms of anxiety. And again, as high as 52%, so more than half of the sample who have between 1% or 49% and 0 of their needs being met have symptoms of anxiety. So here, the group who seems to be reporting the fewest symptoms are those that are actually at work, but actually are adequately protected. So they're still at their work site, but with adequate protections in place by their workplace, have the lowest prevalence of anxiety symptoms, lower even than those who are working remotely. So just to summarise some of the key messages from this work to date. So PPE and infection control, we hear a lot about their importance around reducing transmission of COVID. But I think what these two studies have demonstrated is there's actually a very strong association between the adequacy of both these factors in healthcare and in non-healthcare samples and mental health symptoms. So workers that feel like they're adequately protected through either the adequate provision of PPE or the adequate implementation of infection control procedures do tend to have the lowest symptoms of anxiety and depression, and those who feel the most vulnerable, the least protected, have the highest symptoms of anxiety and depression. So clearly strengthening and monitoring employer-based infection control procedures is important for both healthcare and non-healthcare workers. It seems that PPE seems to be relatively more important among healthcare workers. Infection control seems to be relatively more important among non-healthcare workers. But strengthening and monitoring these symptoms as workplaces reopen is an essential part, because it's not just about infection control, it's also about mental health as well. Working in the workplace when all infection control procedures have been met is associated with the lowest rates of anxiety and depression, lower than even working from home. And so we do need, as workplaces reopen, as potentially we have an increase in counts of COVID infections, we do need to monitor both infection control and PPE adequacy, but also the mental health of workers who are site-based, including healthcare workers, but also including non-healthcare workers as well. For those who are interested in reading more about the healthcare workers survey, we did have a paper which has just been published in the Canadian Journal of Psychiatry. It's freely available, so you can follow this link and you can download it for free for those of you who are interested in curing insomnia late at night. And so you can read about all the survey procedures and what we've done and see the results in more detail. So that's the end of our presentation. I don't know if we're opening up for questions now or not.
Thank you, Peter. Thank you, John. Maybe I'll invite people if they have any questions to let me know. But perhaps I'll get it started with a question or two, and then we'll see if any others have any questions they want to jump in with. I mean, the obvious question in a conference of this nature after a presentation like that is, what are the broader implications that these findings have for the workplace? And you touched on that, I think, with your key findings at the end. But a couple of observations, and then one or the other of you can jump in. I found it interesting that the difference between health and non-health with respect to level of anxiety as it related to ICP. And I was wondering, is that level of efficacy, in other words, awareness in the healthcare sector of what it should look like, and measuring it against that higher standard, or are non-healthcare workplaces reassuring their employees with the ICP more so than that? I mean, it's hard to know, I know, but I mean that was one of the things that struck me. And similarly, interesting that people working remotely would have more anxiety with respect to ICP than people who have been on site, and that's in my mind counterintuitive. But again, it may be measuring something else about what is the effect of working remotely on people. Apparently Google data released some information recently about the increase in online searches during the pandemic related to anxiety and panic attacks. And recently I read an article in the Globe about the proposal for a covatical. Maybe we all need to go on a covatical. So with those comments and observations, Peter, John, I wonder if you can elaborate a little bit more on what this may mean for how we want the workplace to be reacting, particularly as your picture, and as Mario pointed out, your picture, Peter, suggests we're in the second wave. What should we be turning our minds to now?
Yeah, so I'll take the second half of that question, and I'll let John maybe give a little bit of thoughts around why infection control is more important to non-healthcare workers and PPE is more important to healthcare workers. In relation to the question around the people who are working remotely, so we didn't assess the adequacy of infection control for those who are working remotely. They're just a group of workers who are working remotely who had, I think it was about 35% of those workers had symptoms of anxiety, and that's understandable. It could be general anxiety due to the fear of infection. It could be anxiety about trying to work while you've got your kids running around the house, working at a desk, trying to move throughout the day. Those symptoms are, we'd expect that there'd be some level of anxiety among people who are working remotely, even though they're not exposed potentially to workplace-based factors around COVID infection. I think the important part of that study is that among the workers who were site-based, so I think most people, sort of like, well, if you're still having to go to work, that would be a much worse position for you to be in. It'd be much safer for you to stay at home. And I think what that study shows is that actually, if you go to work and you feel like you're protected, your symptoms of anxiety are lower than people who are working at home. And so I think for a lot of people, they like the structure of going into the workplace, but they want to know that if they do that, that they're going to be adequately protected. And I think it's also important to know, before I let John jump in around the PPE stuff, is that everything measured is modifiable. There's not a single thing we measured that a workplace couldn't do if they didn't want to do it. And so I think it's important to understand that. I mean, some of them are obviously a bit harder than others. Ventilation systems is a little bit more complicated than putting up a plexiglass barrier, but they are all modifiable factors. And there's a lot of variety in terms of the experiences of both healthcare and non-healthcare workers at the time that we did the survey in relation to the adequacy of that implementation. But I'll let John, you've maybe got thoughts on the PPE stuff, John, among healthcare workers.
Yeah, and I think Mario will also be talking about this. There was a general lack of confidence in the prescription of what PPE would protect healthcare workers, and the numbers bear that out. There's almost now 7,000 healthcare workers in Ontario who have been infected. Somewhere between 10 and 15 have died, and therefore, as a measure of the efficacy of our preventive measures, it brings a question. A lot of healthcare workers who answered the survey were able to, about a third of them said there was somebody in their workplace who was infected. And so yes, that breeds a lack of confidence in the guidelines, and that obviously will contribute to anxiety. And so if going forward, if we improve our guidelines and get the confidence of healthcare workers in their PPE, that anxiety should reduce. Also, we did measure self-efficacy, and this wasn't discussed in the results here, but the healthcare workers generally score higher in self-efficacy than non-healthcare workers.
Mm.